everyone. My name is Poonam, and I'm really excited to talk to you all today about my project, which was on the long-term impacts of the Zika epidemic on families in the northeast of Brazil, and particularly looking at caregivers raising children with congenital Zika syndrome. And so, as most of you know, in 2015, Brazil experienced a surge in cases of Zika infections, as well as children being born with microcephaly, which is a condition in which they're born with smaller than normal head circumferences. And this led the WHO and the Brazilian government to declare public health emergencies. But about a year ago, in November 2016, the WHO decided to declare an end to the public health emergency, and the Brazilian government sort of followed suit in May of 2017. And the driving question for me was sort of perfectly articulated by Dr. Deborah Dines, who is a very well-known, well-regarded Brazilian feminist anthropologist and law professor. And she said to me, what is the meaning of an emergency, and what are the conditions for it to be fulfilled? And that's sort of the question that I want you all to sort of bear in your minds as I talk through my presentation today. So I've been working on Zika for about a year now, and probably the first big flag for me were these two maps. So not everyone knows that Zika was not evenly distributed throughout Brazil. In fact, if you look at spatial maps of Zika, it was highly concentrated in regions of the country that have been historically marked by inequity, poverty, and underdevelopment. And those are the same regions where Black and Brown, Afro-descendant, indigenous populations tend to be concentrated. So given this unique patterning, you might be asking yourselves, how did the Brazilian government take this into consideration when they were formulating a response? So what are the factors that drove this particular clustering of Zika, and how did the Brazilian government account for those factors when they were developing their response to the epidemic? This is probably one of the most well-known posters of the National Zika Zero campaign. And as you can see, there's a mosquito, I guess their life is being terminated, and underneath it says in Portuguese, a mosquito is not stronger than an entire country. And in theory, this messaging makes a lot of sense because mosquitoes are one of the main routes of transmission of Zika. But one of the questions that sort of arises is, does this messaging, does this singular and narrow focus on mosquito elimination, on vector control, on personal protection against mosquito bites, does that really take into consideration some of the structural factors that led to the epidemic in the first place? So does this messaging take into account why some people are more at risk of getting infected by Zika than others? Does it take into account how some people have the resources and the money and the power to protect themselves against a mosquito bite while others don't? And where is like the gendered dimension in this messaging? We know that women are sort of more vulnerable within the epidemic because they can transmit Zika to their unborn fetus. They can also acquire it sexually. And if they have a child with congenital Zika syndrome, sort of the burdens of caregiving falls largely upon them because of these unequal power dynamics in the country. But all of that, the sexual reproductive health stuff, is kind of left out of this national campaign. And this led many people to believe that the Brazilian government sort of failed to adequately protect the most vulnerable and marginalized within their society. And so now I'm going to put a face to the epidemic. This is Melanie. Melanie is 23 years old. She is the mother of 3 sons, ages 5, 4, and 2. Her youngest son, Davi, was born in August 2015 with congenital Zika syndrome. Melanie did not intend to conceive or have a child when she conceived Davi. She was using oral contraceptives and experienced contraceptive failure. And about 4 months after Davi was born, she actually left her abusive ex-husband of 8 years, so she's now a single mom. And when Davi was born, she was working, but she had to leave her job because of the demands of caregiving and raising Davi with like no other support. Because she doesn't have formal employment, she relies entirely on a benefit from the government that amounts to about $300 a month. That $300 doesn't even cover Davi's medical expenses, let alone all of the other day-to-day basic survival costs that she has in her life. And so she relies financially on a US-based patron who found her in a newspaper and who supports her financially for things like that specialized wheelchair that you see for transport in the picture, and then the feeding tube as well. This is I'm gonna actually go back for a second. So this is the first day that I met Melanie. It was my first day in the field in Brazil. It was July 4th. And she had traveled more or less 2 hours to get to the hospital for one of Debbie's regular checkups. He has several appointments a week, and she came about 15 kilometers. It took her about 2 hours on several buses, and that's relatively close. Many mothers are traveling 5 to 12 hours to get to specialized care centers. This is the community this is actually Melanie Street. Her community is in a municipality on the outskirts of Recife. So again, about 15 kilometers away, not that far in theory, but takes a long time because of inefficient public transport. You can sort of tell in this picture that the public health infrastructure doesn't look like it's at its strongest. There isn't really good trash collection, waste management, there's a lot of standing water that collects, and all of that leads to conditions that are sort of ideal for mosquito proliferation. These are Melanie's 2 older sons, Rafael and Miguel, and one of my pieces for this project was actually called The Other Children, because I think that siblings are often impacted in epidemics in ways that we don't really examine in mainstream narratives, and a good example of that is this next picture. So while I was in Brazil, Debbie got a really severe respiratory infection, and that's really common for children with congenital Zika syndrome. They have suppressed immune systems, and that leaves them really susceptible to these types of infections. And so while he was hospitalized for 2 weeks, Melanie could not leave the hospital. Like even for an hour, she couldn't go get a change of clothes. And she had no one supporting her at this time. She had no family, no friends, no one from her community. It was like her singularly at the hospital. And during this time, she couldn't see her children. Her 2 older sons had to stay with her ex-husband, who was abusive towards her and her children, and who refuses to acknowledge the existence of Debbie. So during that time, she didn't get to see her 2 sons, and her 2 sons didn't get to see her. And when Melanie came home from the hospital, her house was a complete mess. Her boyfriend, who was living with her at the time, there was no food in the house, no water in the house. There was just trash everywhere. So the first thing she had to do was clean the entire house so that she could bring Debbie back home into a safer environment. And this just goes to show just the many layers of heightened maternity is what Deborah Dinas calls it, that Zika demands of caregivers. And I want to be really particular here about saying that these children are loved and they're cherished, and there's nothing about Zika that makes congenital Zika syndrome the tragedy. I think disability is not a tragedy. I don't think these children are tragedies by any means. I think what is tragic about Zika is that the conditions that produced the vulnerability and the conditions that made these women susceptible to Zika have not been addressed and continue to impact these women in ways that lead them to live very precarious lives. So they don't have institutional structural support so that they can live their lives with dignity, so that they can have full protection of their rights. Melanie loves her son, she loves her children, but she's not able to work, she can't go to school. She has, trouble meeting her finances on a month-to-month basis. And everything about her life has sort of been flattened to the role of a caregiver. And I think that's something that we should closely examine. And the women are not victims, right? This is a narrative about victimhood. This is Julia, she's another mother, and she will tell you that she is a nurse, that she is a neuropediatrician, that she is a scientist. Zika has turned her into all of these things because she had to, and she will explain hydrocephaly in more detail than any doctor can. And so it's not that, again, it's not a narrative of victimhood. We call this in public health sort of household production of health. These women are sort of the frontline care providers and scientists who are learning about the epidemic. And so to conclude, Zika has also been a highly politicizing moment for a lot of mothers. This is one of the largest groups in Recife. They're called UMA, which is Union of Mother of Angels, and they are mobilizing, they are organizing to demand their rights. So they're very aware of the fact that their rights have not been protected in this epidemic, and they are demanding accountability from their governments. And so I found this really inspiring. These women take to the streets in hundreds with their children and will deliver signed letters with demands to their local government officials. Thank you.
Hello, everyone. My name is, again, Lauren Clausen, and my project is on sex education in the time of Zika. I am a student at Boston University, and I'm pursuing my master's in public health, and I'm focused on health communication and sex and gender. Health communication being how do we make that messaging that will turn research into action, and sex and gender being how can we have phenomenal sex ed. I am of the thought process that if we had comprehensive sex education for everyone, we'd be in a better place.
I just want to interrupt. If at any time anyone in the back cannot hear, please wave your hand.
Thanks. So I'm so glad I followed Pranam. We've all heard of Zika, right? I became interested in Zika first from the public health perspective. So originally, as Pranam mentioned, we thought that the virus could just be transmitted through mosquitoes, but it was discovered that it could be transmitted sexually. So this was actually a really big deal, right? There isn't another virus that can have both routes of transmission, and so it was an uncharted territory when it came to the response. To fight Zika, it wouldn't be enough to just hand out the mosquito nets and the bug spray. There actually had to be an incorporation of family planning and reproductive health to adequately target the disease. There needed to be education campaigns for both men and women to have safe sex practices, and it was the first time that a public health approach could really be incorporated into the disaster response. So I came to El Salvador, and the project involved the question, did Zika create that window of opportunity to change the way sex ed was both taught and talked about in El Salvador? And the answer, spoiler alert, was no. But I've got 8 more minutes, so let's figure out what I found. So first of all, I speak lightly, but El Salvador is in truly a really tough spot. It is the most dangerous country in the world outside of a war zone. San Salvador is the murder capital of the world. These next few slides basically could be described as, and it gets worse. Violence really affects men and women differently, although a lot of the violence is perpetrated between warring gang factions. Women experience violence very differently. El Salvador leads Latin America in unintended adolescent pregnancy and femicide. 1 in 8 women reports experiencing sexual or physical violence, and of course those numbers are extremely underreported. This was a newspaper headline during my trip, and it translates to 22,000 minors are married to adults. So child marriage was legal at that point, and unfortunately in many cases this was just a way for a rapist to avoid rape charges if they married their pregnant underage victim. To make matters worse, El Salvador is one of 4 countries in the whole world where abortion is illegal under any circumstance. Life of the mother, severe fetal abnormalities. Literally the day I arrived, a 19-year-old rape victim who suffered a miscarriage was convicted for abortion, and she is currently serving a 30-year prison sentence. It's not all bad. There is action on this, of course. There's currently a reform bill in the legislature asking for abortion to be legalized under 4 cases, including life of the mother and severe fetal abnormalities. But human rights groups are working, but of course, the measure has currently stalled. I see all of these as issues, as symptoms of a larger problem. If people don't have accurate and compassionate information about their bodies and about how their bodies interact with other bodies, what do we expect with these problems, right? My question, did Zika change sex ed, after kind of looking at all those determining factors, kind of started to take on a little more of a desperate plea. So when I arrived in El Salvador, this was the sign that was in the airport. So Zika, great. But let's look at the health messaging, right? In the kind of puzzle pieces, we see how to protect yourself against Zika, and it's the mosquito coil, it's the bug spray, it's the mosquito net, which is a little problematic because the mosquitoes that transmit Zika don't come out at night, so the bed nets and sleeping isn't a thing. And then it's protect your body with long sleeves. And another caveat to that is it's 89 degrees, like no one's wearing long sleeves. So I kind of dug in with lots of questions. Everyone I talked to, doctors, nurses, international aid workers, taxi drivers, I would sit down and I would say my question, did Zika change sex ed? And I got a lot of puzzled looks, and without fail, every time I get a weird look and they say, we don't have Zika and we don't have sex ed. So that was a problem, and had to kind of dig into that. This picture is of Dr. Solizario, who was an OBGYN for 30 years. She kind of tried to explain to me why people would even say that there is no Zika. We talked about how maybe it was a reporting problem. Private hospitals and private hospitals don't need to report, so there could be a lot of missing information there. In public hospitals, to actually accurately diagnose Zika, you need a blood test sent to the CDC in Atlanta, and that's probably just not happening. So underreporting could potentially be a really big issue. A lot of the Zika response, and there was a huge response, came from USAID. The money poured in, and while the money did pour in for Zika, a lot of NGOs have ended up using it towards other things as well. As Poonam discussed, like Zika is like those children and families will be affected for their entire lives. But diarrhea is the largest killer of children in El Salvador. You know, the money has never gone to those issues, and so the question is why Zika? And I would be happy to discuss that later. I'll skip some of these for time. In terms of sex ed, when I traveled to a rural community in El Zonte, I talked to this doctor, and we kind of tried to flesh out like where should the sex ed be? Is it in schools or is it in a clinic like this? She said that the number of women who have gotten pregnant during the Zika outbreak hasn't changed at all. There is no sex ed, and it's just not really available. She told me that no one plans their pregnancy in El Salvador. The sex education in public schools is really next to nothing. However, all the information is on the table. This information was on a folding table in the waiting room. So the information is there. The contraception is free and included in national health care, but the political will and kind of social want just isn't there. The culture is extremely socially conservative. This poster is from a women's group that has the women's hands reaching up for their health, their life, and their decision, but held back by the church, the state, and society. If you are a pregnant woman, you will come away with this bag funded by that sweet, sweet Zika money. So you get a very informative pamphlet, mosquito repellent, and 10 condoms. So the messaging that I found had changed, thankfully, was they had just started, like Zika, 2 years old at this point, they had just started to make messaging about how it was sexually transmitted. However, because of cultural factors, it could only be focused on pregnant couples, telling pregnant couples to use condoms. That's best of luck to you. And of course, the people who really need that messaging are unmarried couples, and the sex ed messaging needs to be there as well. I'll kind of skip through a few of these. This is Sandra. She's 21 years old. She has since delivered a healthy baby, but we had talked about how she's never had sex ed. Doctors have never told her about Zika. They told her not to have alcohol and not to drink soda. I think I will move briefly to the end. But I just kind of want to end with when I look back at that original question, I think I maybe got a little ahead of myself. I came to a country wanting maybe too much too soon. Zika was new, right? Like 99% of the research on Zika has happened in the last 2 years. So the ties between microcephaly and Zika have been so recent that most of the NGOs that I talked to literally had hit the ground running and were figuring out as they were going on. And the Salvadorians that I talked to, frankly, just had bigger issues on their hands. I sat in a school office and talked with a principal and a teacher about their kind of like dream sex ed program, and they talked about how if the government could come and provide more sex ed, or if we could have some kind of curriculum. And as I was getting up to leave, he's like, oh wait, and pulled out a box of beautiful USAID, completely comprehensive sex ed like curriculum. covered in dust, sitting in a box. And it's just kind of like, you know, I think another question, or like kind of I left with more questions than answers, of course, but a big one was, what does it really take to change?
Carthargo, which is a small remote town known for its farming. And I was there, which obviously it was very rural. And the girl that I interviewed there, as you can see, her and her family, they own a rose farm. So they're out in the middle of nowhere. And she's about 3 or 4 hours from the Children's Hospital. There's only one in Costa Rica, and that's where she can get her supplies. Stop 3 was Orotina. It's known for its very rural in nature, and it's very poverty driven. And I interviewed this young little girl, which you'll be seeing in the video later. Stop 4 was the beach city of Jaco, which also is very poverty driven as well. And I stayed there and interviewed a young boy who has type 1 diabetes, and he said we were going to his family's beach house. Ended up being just like a shack, and an iguana actually fell on my head while I was sleeping, so it scared me to death. That's where we stayed. Was not expecting that, but it was really interesting, and I really got to know like how he lives and manages type 1 diabetes. Stop 5 was in Punta Arenas. It is a different province from San Jose. And there I met a girl named Daniela who actually has had type 1 diabetes for 26 years. Her life has been very difficult with it. She actually was misdiagnosed when she was younger, and she actually was told, her parents were told that she was dead, but she is living with type 1 diabetes now. And stop 6 was in Huacas in the Guanacaste province. I went up to a different province just to see how kids there can manage it, because it is so much further from the only children's hospital in Costa Rica, the only hospital where they can get their supplies until they turn 15 years old, then they can go to the adult hospital. And I'm going to show a little bit of my video, which gives a better explanation of what I did.
Seguir caminando porque ya me llegaba un momento en que me cansaba y ya no podía seguir, y también me daba mucha sed, y iba mucho al baño. Primero fue que, bueno, mi mamá me levantó en la mañana porque, bueno, yo estaba muy mal, entonces me llevó a una clínica, y en la clínica me hicieron la prueba del azúcar y estaba en 600. Luego me mandaron al hospital y al de Cartago, y después me mandaron al de niños.
The more rural the area, the harder it is to get, appointments, and you don't get seen by an endocrinologist. You get seen by a general physician who is supposed to be qualified in order to treat diabetes. However, we've seen it numerous times here in Costa Rica. That's not good. We don't see a good treatment with the type 1 diabetes patients. They'll usually have a higher HbA1c level, and it's not that great,
O sea, en la escuela nunca te enseñaron que era diabetes tipo 1.
No, bueno, hasta cuando ya me diagnosticaron, fue cuando ya empecé a ver ese tema. Hola, mi nombre es Paula, tengo 8 años y vivo en Costa Rica, en la parte de Orotina. Fui diagnosticada a los creo que 2 años de diabetes, tipo, tuvieron que empezar a aprender cómo era que me ponían la insulina. Le dio un poco miedo primero. De ahí se pusieron antes un poco asustados porque no sabía qué eran. Ahí me inyecto 4 veces al día y 4 veces creo igual.
So that's a little bit of an idea of I was there for 16 days. And actually the last girl that I interviewed, she had a severe low blood sugar level while I was interviewing her and almost passed out, and that's why she
had juice in her hand because she had a severe low blood sugar level and almost had to go to the hospital, which is 3 hours away. So it makes it very difficult for those rural kids. Thank you.
Hi, my name is Anna. I'm from George Washington University. I just graduated in May, and like Kem said, now I live in Somalia. But in the spring of this year, I traveled with another George Washington Fellow to Haiti to report on the unfolding crisis of women's cancers there. Haiti is the poorest country in the Western Hemisphere. While most people know Haiti from the devastating 2010 earthquake that killed over 100,000 people, Haiti is also struggling, like many developing countries, with the rising tide of non-communicable diseases. These diseases, like cancer, are often thought of as diseases of wealthy countries, but low and middle income countries are currently experiencing a double burden of disease, where their populations suffer from both infectious and chronic diseases. Haiti is one of these countries. Haiti suffers from some of the highest rates of breast and cervical cancer in the world. The lack of healthcare systems and available treatment drive these rates. However, the broken healthcare system is not the only cause of the sky-high mortality rates from women's cancers. Improving the healthcare system would not be enough to lower the mortality rate. Breast and cervical cancer patients in Haiti suffer from some of the ugliest forms of stigma towards cancer patients in the world. The stigma around cancer impedes diagnosis and treatment and leaves cancer patients helpless and alone. The first day I arrived in Haiti, I accompanied Innovating Health International, a nonprofit focused on women's cancers, to their offices. There, I met the first of many cancer patients I would talk to over several trips to Haiti. This patient was a young 29-year-old woman named Esther. She had just been diagnosed with stage 4 cervical cancer by another hospital. The treatment she needed was radiation. However, there's no radiation machines in the entire country of Haiti. She would need to travel to the Dominican Republic for treatment, a trip that cost $2,000. She had spent the time since her diagnosis traveling to NGOs, asking them for treatment. She had finally been directed to Innovating Health International to see if they could fund her treatment and her trip to the Dominican Republic. Esther had brought along her 5-year-old daughter to the office. She brought her because her husband left her and a family abandoned her when they found out about the diagnosis. This is not a situation that is unique to Esther. In the US, when someone is diagnosed with cancer, for the most part, their family and community rally around them. This is not the case in Haiti. In Haiti, cancer is considered a death sentence. Many of the women I interviewed did not think cancer was survivable. And the husbands of cancer patients believe this too, and often sever their relationship with the cancer patient once they find out about the diagnosis. In their own research, Innovating Health International has found that 80% of their patients are left by their partner after they are diagnosed. Now, you may be asking yourself, why would their partners leave them? Why would this happen? I was asking myself this when I learned Esther's story. But partnerships and marriages in Haiti work under a very different set of rules than the ones I was used to. In Haiti, women are expected to support their husbands and their children completely, cleaning, cooking, providing emotional support, and so on. They're expected to put themselves dead last, never prioritizing themselves in front of their family. So when they're diagnosed with cancer, their husbands and their partners think that the women will no longer be able to provide for the family, and so they leave them. Sometimes, like in the case of Esther, they leave the children with the woman. Other times, they take them with them. Either way, they leave the woman and they're left to fend for themselves as they start the treatment process. Other women in the community hear about these women. They know what happens to women who are diagnosed with cancer. This is one of the many reasons the majority of breast and cervical cancer patients in Haiti are not diagnosed until their cancer is terminal. After that, little can be done for them. Even when husbands are supportive of their wife's cancer treatment, there are many barriers to preventing women from being diagnosed or treated. Finances prevent many women from seeking care. Haiti's GDP per capita is only $740. Most people live in complete poverty, and some have no exposure to healthcare workers at all. Women also often seek out traditional health healers before trained doctors, hoping to find a traditional remedy for their medical conditions. This lag in diagnosis and treatment drive the skyrocketing mortality rates for both breast and cervical cancer. In the US, more than 80% of patients diagnosed with breast cancer survive. In low and middle income countries, over 90% of patients diagnosed with breast cancer are diagnosed when they're stage 3 or 4, and even the best Western medicine would offer little hope. Likewise, Haiti has the highest incident rate of cervical cancer in the world. Cervical cancer is and should be an entirely preventable disease. Through vaccinations and screenings, no woman should have to die of cervical cancer. And yet in Haiti, more women die of cervical cancer than every other cancer combined. The stigma around cancer creates a desire to delay diagnosis if a woman realizes she is having symptoms of cancer. So then women are diagnosed at later stages. The diagnosis of stage 3 or 4 often means the cancer is terminal. Even though the cancer would have been treatable at stage 1 or 2, this cements the idea in women's minds that the cancer is always a death sentence, so they continue to delay diagnosis. Because the circular logic continues to reinforce itself, it can be very difficult for programs to lessen the stigma. One stigma reduction screening program, a partnership between the Ministry of Health and Innovating Health International, relies on educating the women about the signs and symptoms of cancer, while also giving the women to receive treatment and screening for cervical cancer on the same day. Over the course of several months, I traveled to Haiti 3 different times, one of the perks of being only a 5-hour plane ride away. On my second trip, I traveled to Gonaives in northern Haiti to observe the cervical cancer screening and educational program. We arrived at the hospital in Gonaives. I was armed with my notebook and camera, and Holdy Flores, the IHI program manager, running the cervical cancer screening, carried posters and pamphlets. Holdy joined IHI because she had seen firsthand how women put themselves last. She had seen countless women put their health last and then die painful deaths because of that. When we got to the hospital, Holdy went in to check with the nurses who would be performing the screenings that day. While she was talking with them, women started arriving. They were on the backs of motorcycles, they walked, they rode in cars packed with people. Some had their babies with them, some had left 7 or 8 kids at home that day. But they had all heard that they could get cervical cancer screenings and treatment and decided to make the trip. When Holdy began her speech, spoken in Haitian Creole, I couldn't understand her words, but I could see the light on her face. She was emphatic on the need for cancer screening and treatment. The women were at first hesitant to share their own experiences, but they soon became engaged in the process. Holdy addressed each one, addressing their concerns and telling stories about cancer survivors. After she finished, I interviewed some of the women while they waited in line to get their screening and treatment. I met one woman there, Marie. Her husband had been furious that she had taken the day off to get screening. She had had to miss that day's paycheck, but she had decided to prioritize herself over that day's pay, her health over that day's pay. I take this as a sign of changing times in Haiti. While most women prioritize their husbands and their children, Marie was determined to make sure that she was healthy too. Just like Esther, the young woman who had just been diagnosed with cervical cancer, Marie was fighting for her right to get health care. Perhaps with more women like Holdy educating others, and more women like Marie and Esther defending their right to prioritize themselves and their health care, the tide against Haiti's forgotten epidemic can begin to turn. Thank you.
My name is Erica Anderson. I just graduated from Boston University's Science Journalism program. And I went to Sweden, actually just got back last night, so please forgive any Atlantic-related scatterbrainedness that may happen. And I'm very much kind of in the process of sorting through everything that I've experienced and learned in the past few weeks. But yeah, so my topic is on pharmaceutical pollution in water. So this is not a scientific representation. These are some of the toiletries that I, a mostly healthy 26-year-old, brought on my trip with me, which is a lot of things. So we have runoff in our water, we have runoff from agriculture, we have herbicides, we have pesticides, we have drugs from livestock, and we also have the things that we put on our face, put on our body, put in our hair, and take as drugs. So those, I'm particularly interested in those drugs that aren't measured well in our current regulatory scheme. So usually when a drug is up for approval, we'll look at its toxicity in terms of does it kill certain organisms, algae, water fleas, fish. A lot of the drugs that we take don't act that way. Antidepressants aren't meant to kill, antihistamines wouldn't cause that effect. And so they're generally not taken into account in the current way that we look at and approve drugs. So one drug in particular that is being studied in this context is oxazepam. It's a benzodiazepine, and it is, of course, not designed to cause harm. It's designed to change behavior. If you're looking at a water flea, at algae, you're not going to be able to detect behavioral changes in algae. If you're looking at fish, you're not going to be able to measure it. And the study has really become more possible in the last 20 years because of advances in ecotoxicology. We're able to detect much lower levels of chemicals than we were 50 years ago, even 20 years ago. So this enables us to do different kinds of scientific studies. In particular, here, if you recognize that box up the top, it is part of an Xbox Live or an Xbox gaming system. So the same measurements or the same detection system that is used to pick up your movements playing video games you can use to track fish. on the left side, we have a nice habitat for a small prey fish like perch. On the right side, we have a big predator fish, pike, and I'm not much of a fisherwoman, but from what I understand, if you are fishing for pike, you might even catch 2 pike because 1 pike will eat the one that's on the line. So they are quite aggressive. And on the left-hand side, if you were a small predator fish, a perch, you would want to stay hidden. You wouldn't want to swim out into the open area, as one scientist that I spoke to said, there's a reason that small fish are anxious. If you are small, and in a big in the waterway with pike, you should be nervous. As scientists work to study new ways to measure these effects, they can use tools like this, where they will expose fish to, for example, oxazepam, place them on the left-hand side, and then measure how long it takes to swim out towards the pike. If they swim out towards the pike, then they have a little fish's eye view here. If they swim out towards the pike, then they have an increased measure of boldness. If they stay hidden, as many as the unaffected fish do, then they that would be what an unexposed fish would do. In particular, so that's great for lab studies. It's important when doing toxicology studies to break it down in the lab to gauge the effects of individual chemicals. But of course, in the waterways, we don't have 1 fish, 1 chemical in a small tank. We have a whole bunch of fish in a lake. So these are receivers that are placed throughout lakes, ponds in northern Sweden, and they can pick up sound signals that little tiny, well, they're actually not that tiny, they can be a couple inches depending on the size of the fish. Tags that are placed in the fish, and then they can pick up different movement patterns and different behavioral patterns, so you can gauge what an exposed fish actually does in a natural situation. So they had some interesting findings that though the small fish become bolder, the big fish, when exposed to the same benzodiazepine, become more lazy. So perhaps there is no net effect on predation, which is an interesting finding, but in terms of the whole greater scheme of ecotoxicology, really illustrates the difficulty of gauging the effects of a whole soup of contaminants that we have in our waters and the entire interaction along the trophic system from the smallest to the largest. It's really quite a challenge to quantify these effects. So that brings us to sort of the philosophy and regulatory side of things. How do we make decisions about this, and what needs to be done before we can make any further changes? So I've been talking to different stakeholders. Of course, we have the scientific researchers who are working in labs, in lakes, to try to look at these effects. We have government and regulatory agencies that need to have more data before they could make a decision. In Europe, at least, even a demonstrated environmental effect cannot affect the approval of a medication. So even if you were to demonstrate this affects fish in a certain way, it would, even if it were to kill off a population of fish, it can't derail the approval of a drug. In veterinary instances, it can. So we really start to get into sort of the regulatory science and the regulatory effects that come into play here. The pharmaceutical companies definitely agree that this is an issue that they need to look at least in Sweden, in particular where I was. I had gone there because there was so much research coming out of Sweden, and every time I asked someone, so why is this localized here? What is driving so much research going on in this country? There was a program from 2008 to 2015 funded by the Swedish government actually specifically to look at this. And funnily enough, lots of people that I spoke to said it's because Swedes like to be outside and we value being green, we value our natural resources. I saw that as definitely a factor when I was walking in Stockholm and saw someone practicing kayak rolls in, so like if you flipped over your kayak and you came back up, practicing that right in the waterway right outside of like the equivalent of the Hudson River, and it's definitely not something you would see here. So yeah, so pharmaceutical companies agree that this is something that we should take a look at, but that we need more data. And of course, people who eat fish and drink water, all of us have a right to clean water, have a right to health, and not a single person that I spoke to said we should not use drugs because they have environmental effects. Of course, we should continue to use pharmaceuticals. They're essential to human health, but so is the right to clean water. So as we, the world's population grows, and as we continue to use pharmaceuticals and expand access to populations, it's important to gauge the effects that they're having and ways that we could remove them, or perhaps even design drugs differently so that they could have mitigated environmental effects.
Okay, well, thank you all. We learned a lot, and now we'd like to have questions. Would somebody like to get started? Well, yes. Yes.
Okay, so my question is actually for Puna. So I'm originally from Brazil, but I'm from the south of Brazil, which means that I'm fortunate enough to live in an area that is, I guess, wealthy enough that we don't have to deal with those sort of diseases and viruses as much as in Brazil. But one thing that I do know is that the mosquito that transmits the Zika virus is also the mosquito that transmits the dengue virus, which has been an ongoing issue in Brazil for decades. So my question, I don't even know if you know the answer, but did you see any sort of long-term project from the government, or because it's really easy to deal with problems when they're like short-term and like they drop the emergency state and then now let's just not do anything about it. So I guess my question is, did you see any sort of long-term let's combat the Aedes aegypti mosquito, or was it very Zika virus specific?
Yeah, that's a really good question. So the Zika epidemic co-occurred with another epidemic in the Northeast. It was a dengue epidemic at the same time, and there's a lot of scientific interest in understanding what is the interaction between these epidemics, and did the dengue and Zika epidemics happening at the same time lead to sort of exacerbated effects. In terms of the response, the Zika Zero campaign is part of a larger No Mosquito campaign, and the No Mosquito campaign, of course, looks at chikungunya, dengue, and Zika. What's curious about those campaigns is that they're not very structurally focused, so they're very interested in how do we spray all of these communities so that we kill all the mosquitoes, and how do we eliminate mosquito breeding zones and things like that. So they're very focused on sort of these short-term strategies. And I did ask a lot of government officials, okay, so how are we thinking about just better public health infrastructure? And what about building cleaner neighborhoods, looking at waste management, sewage systems, clean water, trash collection, all of these things. And that's on their horizon. I got some curious answers around that. There was a lot of, at the local and state level saying oh, these things have to happen federally. At the federal level saying that we have to focus on immediate sort of relief and disaster response. And so there was a lot of sort of I don't know if it's finger pointing, but just saying oh, we don't have the funding and sources for that. That has to come from higher up, and higher up saying that they're working on just sort of containing the epidemic, most immediate impacts. So it's not that they're not aware. The Human Rights Watch did a really good investigative report of Zika and basically called that out. So they're aware of it. I wouldn't say that the strongest plans are in place currently.
All right, thank you.
Other questions? Okay. I guess I have a question for you, Lauren. You said when you got to El Salvador that you thought that sex education was not in place. Do you see any like hope for the future in terms of that?
I do see hope for the future. I think it kind of almost what I was just talking about, kind of these structural changes are just going to take a long time. And the government just has no capacity right now. They're hemorrhaging people with immigration. The gang violence is extremely problematic. There's an election coming up that everyone's kind of waiting to see what's next, and the political party will determine the educational curriculum. One party is more conservative than the other, and so I think it's really up in the air. But I think the thing that was really, that did make me like not horrifically depressed was I went there really nervous about talking about a controversial, a taboo topic. The majority of people I talked to were so open, and they knew, they're like, yes, this is a problem. Why aren't women's rights prioritized? Of course we should have sex ed. I talked to a local community health educator who had these like revolutionary ideas about sex ed that should start at 10 years old, but he's one guy in basically a county, so I think the tides are changing, but they need the financial backing, they need that structural support that just isn't there right now.
Yes, Patrick.
Lauren, my question is also for you. I've read that there's a U.S. policy that prohibits aid from paying for overseas portions. Since you were talking a lot about USAID in El Salvador, did that come up as an issue at all?
Yeah, it's the Mexico City policy that prevents funding. Sorry. Yes and no. None of the NGOs were involved in abortion care, and so they are able to still take funding. However, that impacts how NGOs ask for grant money. So basically, if you're going to take USAID money, you can't talk about abortion, and that's how it happens. So organizations that aren't USAID funded, local organizations, are the one, like the pictures of protests and kind of the signs with the women and dealing with the recent case with Evelyn. Those are all local organizations, so that's not taking international funding. Those are on the ground Salvadorians who are trying to change that
It's called
policy.
the Hyde Amendment.
Yeah.
Right.
No, that's the
The Hyde Amendment's in the
Yes,
US.
the Hyde Amendment's for the U.S. and then
But we
the
can never-
Mexico
yeah.
City global gag rules for international aid.
Okay.
A question for Jesse about the diabetes in Costa Rica. Just I'm curious about how you found the subjects you reported on as you made your trip, and also just you chose to make a video. Was there anything you were doing? Just how you shot that, what your concept was in making the video.
Yeah, well, I really wanted to focus on specific children, just to make it more personal and relatable. The girl that was actually my translator and drove me around everywhere, she set up the interviews because she is the head of the only organization in all of Costa Rica to support type 1 diabetes. So she had a huge database, and we just narrowed it down to which kids want to talk, which kids live in the most rural areas, and who would let me stay with them for the time that I was there. And your question for camera-wise, I wanted to keep it simple so they weren't overwhelmed. So I only took my DSLR and a lavalier. Other than that, I use my phone just because kids, they love those big cameras holding them, but once they're in front of it, they kind of shut down. So a lot of the time it was just me and my phone, and that's
I know a lot of people who work in global health journalism use NGOs as a way to get at sources or stories, but how do you deal with balancing the fact that you are, either covering them or not covering, deciding not to cover them because you're using them? How do you balance the issue of they're helping you maybe find sources and information, but at the same time, you need to be able to think about them critically and what they're doing critically. Cover that.
Are you asking me?
Anyone.
Well, I think you all work with NGOs, right? So anyone can answer. Did you?
I worked. Oh,
Go ahead. No, you go ahead.
I mean, I worked on and off. Half the trip I was with the head of the NGO, and then half the trip I was out on my own, driving to different clinics, using Google Translate a lot. Came in handy, but yeah, you definitely have to balance and take that into consideration. Like they're helping you, but like you really do have to consider that aspect of how they help you.
Yeah, so I worked with one NGO primarily, which there's only 2 NGOs in all of Haiti that work on this issue, so I was kind of limited in my options. But what I also did to kind of bring that counterbalance was interview experts outside of the NGO who had never worked with the NGO before to talk about the screening methods that they're using, the treatment methods, to kind of get a balanced perspective on what actually works for cervical and breast cancer treatment.
And now, before we wrap up, I just want to ask Anna to tell us a little bit, like 1 minute or less, what you're doing in Somalia. I think most of us in the room will want to know.
Yeah, so
She went from Haiti to Somalia.
Yeah, exactly. I moved a week after graduation. So I'm a project officer with a consulting company there. So we consult with the NGOs in the area who are working all over Somalia to evaluate their projects that they're doing, the work that they're doing, and also provide data for them on, for example, malnutrition, because there's a famine going on, and all sorts of other data that they're interested in. So my last project was on maternal and child health and figuring out how women of reproductive age are getting information about reproductive health services so that we can use those same avenues to target them later.
And were you there for the boundary?
No, I was actually here, but yeah, a couple coworkers are affected by it. So.
And based in Mogadishu?
I'm based in Hargeisa, but a lot of my coworkers are from South Central.
Okay, well, thank you very much. That was excellent.